Hello, happy Thursday. If you're watching this on a Thursday, um, day one of topic two. So we are rocking and rolling. And in this topic section, we are talking about assessment and diagnosis, and just how we find the answers. What is the protocol? What does that process even look like? And I can tell you, after all these years, I still do get a little bit nervous assigning a diagnosis. And probably 9 times out of 10, right now in the work that I do, I am only assigning a diagnosis when I'm billing insurance. And I've not found an insurance as of yet that doesn't require some sort of diagnosis and ongoing assessment for an individual to meet the criteria in order to get mental health services provided. So that always comes with an informed consent. Just reminding the client or the patient, hey, I have to assign this diagnosis. We talk through it. Obviously, they've already kind of gone over all the symptoms. We've both agreed that those symptoms are what they've described. And then I will use the DSM-5 to show here is the criteria, and you've met criteria. So this is the diagnosis that I will be using to bill insurance. So that's where I see it used the most. Hospitals, psychiatric hospitals, that's also going to be a lot of times insurance based. And in order to get admitted, oftentimes, more often than not, you have to have a mental health diagnosis if it's for a mental health admission. So I posted a PowerPoint called The Hardest Parts of Assessment and Diagnosis in Social Work, holding complexity with compassion, because this is such a complex process, as some of you know. We are examining our values, the challenges, and kind of, the task that we have been called upon to do, which is figure out what's going on. Use assessment tools to evaluate X, Y, or Z. And that can be quite overwhelming, but there's good supervision, hopefully, at your internship or placement. And then once you graduate and get a job, hopefully you'll also have some clinical supervision and support to kind of help you navigate that. So we're trying to balance person and environment fit with the DSM labels, because we're trying to see the person beyond the diagnosis. So oftentimes, I'll focus on symptoms. Yeah, we have this diagnosis, but really what we're looking at is you, the person, the client, the patient. How do these symptoms affect or compromise your everyday life? Getting out of bed, going to work, parenting, partnering, being a roommate, being a student. So how do all these symptoms and criteria affect you? Now that we've decided that you have been diagnosed with an anxiety disorder, not otherwise specified, let's say. We're also looking for culture and contextual bias. The DSM is not culturally neutral, as maybe you have found out so far by doing the reading in the topics, or just on your own, or doing some assessments. So really looking for assessment tools that consider race, culture, ethnicity in the evaluation. Okay, because some behaviors or disorders that can present, let's say, as maybe even psychotic or abnormal, or on and on and on, could be cultural. That was not the best example, but we can talk more about that if anybody has any questions. But let's say somebody is speaking in tongues. I've heard somebody say, no, they're just like shouting and, just it's making no sense. And then the person's advocate says, no, they are praying, making a statement of faith, what have you. It is not them just saying a bunch of random stuff in a psychotic episode. So that's kind of a watered down example. We are also looking at trauma versus mental illness. Trauma can mimic anxiety, depression, or even ADHD, where symptoms are heightened and exaggerated when someone is in a state of traumatic distress, either from a recent event or they're processing past trauma. So really fleshing out, what that looks like. And again, there are assessment tools for that. Sometimes we have incomplete information. We just don't have enough information in order to form a diagnosis. That might be because a person is just not able to give us all the information. They are so depressed. They don't know. They don't know what their day-to-day looks like. Their affect definitely seems like they are down. They report being down, but can't really tell you why. And if we are in a hospital type setting, sometimes we don't have to assign a diagnosis. We can assign what is called a provisional diagnosis, where that it can change as we do further assessment once the person has been at the hospital for 1 or 2 days. Trying to think of more kind of off the top of my head, just our own intuition of what we see. So empathy or intuition, rather, are tools and not evidence. Okay. So I want you to kind of think about what that means. So just kind of have a sense that it might be this. I have a sense that they could go a little bit further with their story. Yes, maybe. That's not always exact evidence. So really, kind of examining all the criteria, all the information given to you, and not forming necessarily a decision based off intuition or judgment. We really have to watch our countertransference and our bias. So we have to be really self-aware. If a person reminds us of somebody and we're like, whoa, I'm feeling some type of a way, and that person presented as this, and now this person that I'm in front of is presenting with the same symptoms they must be going through. That's countertransference coming into the room. Sometimes bias can look like, this person is like oversharing. They are highly anxious right now, but do they really meet criteria? Or heard a clinician say one time, what they're talking about that's making them anxious really shouldn't be making them anxious. That's an opinion. Okay. When you're saying, give me an example of what makes you anxious, distressed, not sleep at night, not hungry, what have you, they list off, whatever it is they can give example wise. And we think to ourselves, that's what's making you anxious. That's what's making you depressed. That's why you think you have ADHD. We have to really pull our own bias from the diagnosis or the assessment, what have you. So again, look through the information, the PowerPoint that I gave you, and I am going to ask you some questions in the form of a cat. I'm still getting used to that, but I'm going to use this PowerPoint just to ask some questions. In the PowerPoint that I shared with you, there are a few podcasts. You don't have to watch them, read them, watch or listen to the podcast. I'm guessing a podcast, you listen to it. But you don't need to worry about that. If you want to, because you're curious, great. But I'm just going to be asking you more general questions about how do you feel about diagnosing? Are you diagnosing individuals right now in your internship or your job, or have you done it in the past? Which mental illness do you feel most uncomfortable about diagnosing? Maybe that's just because you don't know enough about it. Maybe it's because you just worry about getting it wrong, what have you. So going to be putting this in the form of a cat, an optional cat, and I'm still learning how to do that. So have a wonderful day and go antelopes. Is that what we say? Lopes up. Anyway, take care.